Hello everybody, and welcome to our HIV 101 webinar series. Today we're going to be talking about HIV testing. My name is Stefan Perez, and I'm an HIV clinical specialist with Health HIV and the National Center for HIV Care in Minority Communities. I'd like to thank you today for taking the time to listen to our webinar. As we move forward, we're going to be discussing CDC HIV testing guidelines and recommendations. We're also going to be talking about some current HIV testing strategies. We're going to be discussing the window period, in particular how it relates to HIV infection and testing strategies. And then we'll talk about some of the various types of HIV tests that are currently offered and available. Let's start by talking a little bit about screening for HIV infection. In all healthcare settings, screening should be routine for all patients aged 13 to 64 years. And of course, this is from the Centers for Disease Control, the revised recommendation for HIV testing of adults, adolescents, and pregnant women in the healthcare setting. There's a caveat to this, however, unless the prevalence of undiagnosed HIV infection in their patients has been documented to be less than 0.1%. So in the absence of existing data for HIV prevalence, healthcare providers should initiate voluntary HIV screening until they establish that the diagnostic yield is less than 1 per 1,000 patients screened, at which point such screening may no longer be warranted. In addition to these guidelines, all patients initiating treatment for TB should be screened routinely for HIV infection. And of course, all patients seeking treatment for sexually transmitted diseases or infections, and of course, all pregnant patients should be screened for HIV infection. Now, when we talk about screening, it's very important to also talk about repeat screening and the criterion for repeat screening. As we can all suspect, persons who are at high risk for HIV should be rescreened at least annually. This could include injection drug users and their sex partners, persons who exchange sex for money or drugs, sex partners of HIV-infected persons, men who have sex with men, or heterosexual persons who themselves or whose sex partners have had more than one sex partner since their most recent HIV test. So basically, a man who has sex with men or a heterosexual person who has had multiple sex partners since their last HIV test, or before initiating a new sexual relationship. And these last two are important. Occupational exposure, of course, for the source patient, but also clinical judgment for high-risk patients. It's important for providers to screen their patients for high-risk sexual behavior and use their clinical judgment in determining how often and who should be rescreened for HIV infection. When talking about routine HIV testing, we hear a lot about opt-out testing procedures. And the opt-out testing really refers to the process of informing that an HIV test is planned unless they decline. Of course, this needs to be in accordance with state and local law. It's important to remember that CDC guidelines do not supersede state or local regulations regarding informed consent procedures. So it's really important to inquire about the policies and procedures of your institution about HIV consent and opt-out testing. It's important to provide at least oral or, if possible, written information about HIV infection, and really important to talk about what the meaning of a positive or negative test result is. It's also important to provide an opportunity to ask questions and have informational material available readily if it's asked for by the patient. And remember that, again, this is going to vary from place to place and state to state, but no separate written consent should be necessary. And it's really important also to document if a patient declines the test. Important to document why the patient declined, and of course whether or not the patient declined. Routine voluntary testing for HIV is recommended like other treatable conditions like hypertension or breast cancer or colon cancer, because it's remembered that it can be diagnosed before symptoms develop. We know that screening is reliable, it's non-invasive, in many cases it's inexpensive, and because HIV is a treatable disease, the benefits of screening outweigh the cost. And routine opt-out testing procedures replace previous practice recommendations requiring specific informed consent and HIV test counseling. Also, when discussing HIV testing, remember, as we said before, oral or written information about HIV tests should be provided. Really want to focus in on that oral piece, because oral information in many cases can be just as good as written information about HIV tests if you can take the time or find the time to explain the test and the results of the test. The CDC does recommend testing without risk assessment and prevention counseling, and this was really meant to sort of bypass the need for prevention counseling that was sometimes becoming a barrier to performing the test, because many busy clinicians, as we all know, do not necessarily have time to do comprehensive prevention counseling and risk assessment with every HIV test that they order. So the CDC put in this recommendation to really help to sort of break down in what sometimes could be seen as a barrier to performing HIV testing in a healthcare setting. And then this is really, really important. Positive test results should include post-test counseling. Again, positive test results should include the following in the post-test counseling. HIV infection is a treatable disease. Important to tell the patient and educate them around ways to limit transmission of the virus. Very important to give them information around disclosure and assist with disclosure if possible. And then, of course, linkage to care. We all know that linkage to care after a positive test result is integral in establishing care and maintaining a positive outcome for that patient. Now, let's talk a little bit about the different types of HIV testing that is available. The first type of HIV testing is a very common one that you likely are all familiar with, and this is the antibody test, either in the form of an ELISA or EIA, and in a serum form. Antibodies, remember, are detectable within about 6 to 8 weeks of initial infection. This is the usual screening test for HIV infection, and many of the tests look for HIV 1 and 2 antibodies. The conventional way is through serum or oral fluid that is sent out to a lab. The rapid testing does include whole blood, plasma, or oral fluid. You can get the results in about 10 to 20 minutes. And it must be confirmed with an ELISA or Western blot. Same goes for the conventional serum or oral fluid that's sent out to a lab. If it's positive on the EIA, a confirmatory Western blot will be sent. Now, it's important to remember that antibodies are detectable at about 6 to 8 weeks, but 50% of patients will have seropositivity at around 3 to 4 weeks. Also, when talking about antibody test, I do want to highlight the Western blot, because this is that confirmatory test that looks for specific antibodies to the viral protein. And when you read a Western blot, if any of you have had the chance to look at one in detail, you'll notice that it gives a list of bands and has the criteria for at least 2 of the following bands: a P24 antigen, a GP41, a GP160 or 120. Negative is read as no bands present. And indeterminate results could be that bands are present, but they do not meet the criteria for infection. What this could mean is that the patient is in the process of seroconverting. They could have advanced HIV disease with a loss of antibody response. You have to consider that there could be an infection with HIV-2. There could also be a cross-reacting antibody from blood transfusions, from pregnancy, a recent influenza vaccine, or a collagen or vascular disease. It's really important in these cases to check a HIV RNA and do a repeat antibody test in 1 month. Now, that sort of leads us into this window period when we talk about HIV testing. And many of you have probably heard about this window period before. And this is the time that the immune system takes to produce enough antibodies as to be detected by one of the antibody tests. So we sort of call it the window period. Most people will develop detectable antibodies, again, within 2 to 8 weeks, again, with 50% around 3 to 4 weeks. The average is about, again, 25 days. So repeat testing should be considered about 3 months after the possible exposure occurred to account for the possibility of a false negative when the person is not yet producing those antibodies to mount a positive antibody test. In very rare cases, it can take up to 6 months to develop the antibodies, but for the most part, 97% of persons will develop antibodies within the first 3 months following their infection. But again, we do want to educate our patients when we're doing HIV testing about these window periods so that they know if they had an exposure in September, it's possible that they could still have a positive test result or a false negative test result all the way out to 3 months after, although highly unlikely. Other HIV testing that's available today are antigen tests. The P24 Antigen Test is probably a test that you've all heard of. It is approved for the diagnosis of acute HIV infection. It has a low sensitivity. HIV RNA is often used if acute HIV infection is suspected. This test was approved for the hopes of perhaps diagnosing HIV infection earlier. There is a combo P24 antigen antibody test combination assay that is available, again in the hopes of possibly diagnosing persons earlier on in acute retroviral syndrome or in the course of their HIV infection, where the antibody test may not necessarily become positive or may be indeterminate. But really the gold standard is for quantitative HIV RNA assay, which is a viral load. This is a gold standard for diagnosing acute HIV infection. Remember that in acute HIV infection, the viral load is going to be very high, most likely. So a viral RNA assay or a viral load will be very valuable and is the gold standard for diagnosing acute HIV infection if suspected. A qualitative HIV RNA is also available. This is one of those tests that will give you a detected or non-detected response on your lab report. This is what we use to diagnose or to screen infants who are maybe post-exposure immediately after birth. So this is what is used for testing infants, but also could be useful in detecting acute HIV infection. However, this is not a viral load test. It will not give you a high viral load or a low viral load. It will only tell you if there is HIV RNA detected in the serum. So in summary, the CDC guidelines state that in all healthcare settings, screening should be routine for patients 13 to 64. So really important to use these guidelines, offer the test, and document whether or not the test was given or if the test was refused and why. There's multiple reasons for repeat screening, many of which we discussed in the course of this presentation. But always remember that if you're screening a patient for sexually transmitted infections, then it's important to also be screening them for HIV as well. And there are many, many indications to perform targeted testing or repeat screening beyond the routine screening guidelines. And we'll also have to be very careful to remember that that there are many patients that may fall out of these routine screening or repeat screening guidelines. We sometimes see patients whose only risk factor is that they were in a monogamous relationship, but their partner has been going outside of the relationship without that knowledge. So that patient may have for years thought that they were not at risk for HIV infection, all the while their partner has been engaging in unsafe sexual activity outside of the relationship. So it's really important to assess our patients at each and every visit for any changes in their risk factors. Patients may test HIV negative during the window period. It's really important to retest patients, do a comprehensive risk assessment, and if you suspect that they may be testing negative during that window period, or you suspect acute retroviral syndrome or seroconversion, that you do the diagnostic test of a quantitative HIV viral load test to confirm your suspicions. And then very, very important when doing HIV testing to remember that HIV testing laws and requirements do vary from state to state, so it's important to check with your local health department or local government or facility around their own testing laws and regulations. I'd like to thank you for taking the time today to listen to our webinar. If you have any questions, please feel free to send me an email at stefan@healthhiv.org. Thank you again, and I look forward to speaking with you next time.